Electrolyte abnormalities. We'll see potassium abnormalities in this video. So dietary requirement of potassium in a child is 1 to 2 milliequivalents per kg body weight per day. 2 to 3 milliequivalents per kg per day is for sodium. Hypokalemia is defined as serum potassium levels less than 3.5 milliequivalents per liter. If it is more than 5.5, we call it hyperkalemia. Why will hypokalemia occur? It's because of excessive loss in the GIT or kidney. So because of diarrhea, laxative use, RTA, that is renal tubular acidosis, distal or proximal varieties, Gitelman syndrome, Bartter syndrome, Cushing's syndrome due to adrenal adenoma or hyperplasia causing a lot of pee, and hypomagnesemia. Drugs like diuretics, thiazide or furosemide, like loop diuretics or any other diuretics, cisplatin, aminoglycosides, amphotericin, theophylline, beta agonist. All these drugs can also cause. Others include alkalosis, spurious hypokalemia and leukemia, anorexia nervosa. Symptoms are non-specific and related to the muscle weakness, and cardiac function, cardiac arrhythmias. So muscle weakness and cardiac arrhythmias are common in case of hypokalemia. ECG changes shows prominent U wave, which is the earliest one, flattening and inversion of the T wave, prolonged PR interval, wide QRS, and a depressed SD segment, QT prolongation. All these things happen in case of hypokalemia. So hypokalemia's cutoff is 3.5 milliequivalents per liter. Causes include excessive loss in the GIT or the kidney, or diuretics, or others such as anorexia and alkalosis. Spurious hypokalemia and leukemia. Hyperkalemia, the cutoff is more than 5.5 milliequivalents per liter. Decreased renal excretion of potassium, or transcellular shift, and other causes. Decreased renal excretion occurs because of renal failure, Addison disease, CAH, congenital adrenal hyperplasia, which is 21 hydroxylase deficiency, and 3 beta HSD deficiency, hydroxysteroid dehydrogenase deficiency. ACE inhibitors, angiotensin II antagonist, NSAIDs, potassium sparing diuretics, heparin, trimethoprim, pentamidine, cyclosporin. Just remember renal failure, CAH, and Addison disease, NSAIDs, potassium sparing diuretics, ACE inhibitors, and ARBs. இது போதும். If you want, you can remember cyclosporin, otherwise no need. So decreased renal excretion is due to renal failure, CAH and Addison disease, and then drugs like ACE inhibitors, ARBs, potassium sparing diuretics, cyclosporin, NSAIDs. Okay, all these drugs. Transcellular shift, that is acidosis, rhabdomyolysis, tumor lysis syndrome, insulin deficiency, digitalis, succinyl malignant hyperthermia, exercise. So transcellular shift, okay, because of problem with the, okay, so as such exercise. So like the person is exercising, or there is malignant hyperthermia, so we know exercise and heat, and then acid, exercise, heat, acid, and then death, which is rhabdomyolysis and tumor lysis syndrome. And then insulin is going to take up a lot of potassium, but insulin deficiency is going to cause a lot of potassium to be retained in the system. Succinyl and digitalis is, that's it, enough. Others such as blood transfusion, spurious high value in case of hemolysis, thrombocytosis, leukocytosis. Okay, patients may present with nausea, vomiting, muscle weakness, fatigue, ileus, and paresthesia. So the person presents with ileus in case of hyperkalemia. ECG shows tall, tented. Okay, so we'll just contrast the hypo and hyperkalemia. ECG. Prolonged PR, wide QRS, depressed SD segment is seen in both of these things. T wave inversion and U wave is present in case of hypokalemia. So potassium கம்மியாச்சுனாக்கா T வேவும் கீழே போயிடும். So கீழே போயிடும். Okay, potassium கீழே போச்சுன்னா T வேவும் கீழே போயிடும். That is T wave inversion. Hyperkalemia causes tall T wave. So when the potassium is high, the T wave is high too. Otherwise, a prominent U wave is the earliest finding in hypokalemia.